Now,
good evening, everyone, and welcome to today's webinar. That's what's new in flu, what are the current challenges and the solution options which are ahead. And for the same, today we have with us Dr. Sitesh Roy, and I would like to take a moment to introduce our speaker today, Dr. Sitesh Roy. So Dr. Sitesh Roy is a US certified allergist and immunologist and asthma specialist. Dr. Roy is a founder of Dr. Roy Health Solution Clinic Mumbai, and he is an ex-associate professor of pediatric and medicine and director of Jackson Medical Mall Allergy Immunology Clinic USA from 2002 to 2010. Dr. Roy also had the fellowship in allergy and immunology at National Jewish Medical and Research Center of University of Colorado School of Medicine. Along with that, he is a fellow of American Academy of Pediatrics, the American Academy of Allergy, Asthma and Immunology, and the American College of Allergy, Asthma and Immunology. Dr. Roy is a diplomat of American Board of Allergy and Immunology, and he is listed among the best doctor in America in 2005, 2006, 2007, 2008, 2009, 2010, 11, 12, and Guide to America's Top Physician from 2005 to 2010. Author of original articles and publications for the leading medical journals internationally, and the first textbook chapter on stress and allergy diseases in the Psycho-Neuroimmunology, that is 4th edition, textbook 4th edition. In addition to that, Dr. Sitesh Roy is TEDx speaker, he is allergist, clinical immunologist, and a trusted asthma specialist and holistic healing specialist today. So with this introductory note, I'll request Dr. Sitesh Roy to take ahead.
Thank you very much, Mr. Manohar, and thank you to the Hetero team for organizing this webinar today. A warm welcome to all our attendees from the Kolkata and surrounding areas. Namaskar. The topic that I'll be speaking about today is influenza. And we all know that this has been the bane of our existence for many, many years now. And certainly recognizing pandemics that have occurred in the past, including the pandemic of 1918 to 1920, where people, almost 5 crore people lost their lives to influenza. Which was called the Spanish flu, but actually began in the United States of America and spread to Spain during World War I. And from there, eventually spread to the entire world. Took about 1.7 crore people died in India because there were a lot of soldiers who went off for with the British Army to different parts of the world and came back to India at different points and brought the flu here. And with a lot of malnutrition and not good care, literally crores of people lost their lives. So we've had influenza in our midst for over 100 years now. And even today, we face challenges, which we will talk about in not just what the challenges are, but also understanding influenza and its complications. Finding the clinical evidence for Oseltamivir. Oseltamivir is the only orally approved agent since 1999 for the treatment of influenza. And then the guideline recommendations for empiric use of Oseltamivir. We know that the H3N2 virus, you can see this first article in the Times of India, March 4th, spate of high fever and cough cases. Towards the mid of March, we had over 3,000 officially reported cases of H3N2. Prior to that, we had the swine flu, almost like a endemic epidemic that occurred all across India few months earlier. Cold wave, fog and rising pollution, surge in seasonal flu cases in Jan.
Sir,
and then yes.
Sorry to disturb you. The screen is not getting featured full screen. So request you to please go on a full screen, sir.
I have shared it's showing up as a full screen on my thing. Can you go ahead and share it?
Yeah, yes. Okay, no issues.
So essentially, between the swine flu pandemic or epidemic rather that occurred somewhere in the months of December and Jan to the presence of influenza in the H3N2, which is influenza A format, that came up in essentially in the month of uh, March and April largely. We've had a lot of cases, and certainly in all of these cases, the issue that has been there is that uh, there is no there hasn't been enough done. Can we move the slides forward, please?
Yeah.
Yeah. Okay. That's good enough. So while we think of this as a seasonal issue, we forget to understand that influenza cases are actually present all year round. In India, we have a unique situation where we get spike in cases in the second half of monsoon in July, August, sometimes into September. Then we have a lull for October, November, and again from December, Jan, Feb into March. This time the major outbreak was not in December, Jan, Feb. It was mostly in March and April that we are seeing a significant rise in cases. But influenza, which has a winter season in the northern hemisphere in US, Canada, other parts of the world, and then again when there is winter in Australia, New Zealand, which is a different part of the year. India seems to get flu at both of those times, and we have both the northern hemisphere viruses of influenza as well as the southern hemisphere strains of the influenza. And infection in pediatric patients can be dragged and prolonged. Fever and cough are the top symptoms. Runny nose, cold, headache, breathlessness, risk of pneumonias with the H3N2 virus, and certainly wheezing, throat irritation, runny nose, breathing difficulties. These are well known, and if there are pre-existing conditions, it gets even worse. Next slide. So as we discussed, fever and cough, runny nose, headache, fever can be usually above 101, but sometimes can be low grade also. Body ache, a very common feature, myalgia, muscle aches can be there. Sore throat, vomiting, diarrhea. So many times these symptoms make it hard to differentiate from any other virus. Most importantly, the COVID-19 cases. We've also had a respiratory syncytial virus, RSV. We've had rhinovirus, which is a common cold virus, but that won't give as much of systemic symptoms as the regular influenza would. So with all of these, we recognize there's a lot of overlap, and we shall talk about this in the latter part of the presentation also. Next slide, please. So when we look at the update on seasonal influenza in India, an integrated surveillance for influenza-like illness and severe acute respiratory illness, which has multiple sites, 28 sites all across India, and it's a centrally organized system housed at ICMR in Institute of Virology in Pune. WHO has its collaboration with that, and during the period of first 9 weeks of 2023, as you can see, there were progressively increasing cases of influenza A, H3N2. The H1N1 is what we know as the swine flu, and the influenza B also was very much active. Next slide. The healthcare related challenges that we face, obviously, because when you have an influenza like illness, it's hard to differentiate whether it is influenza or is it one of the other viruses that I just mentioned. Add to the mix, we've also had adenovirus, which gives conjunctivitis. It also gives upper and lower respiratory symptoms. Combine that with the fact that the new variant of COVID-19, the Omicron XBB 1.16, is also giving conjunctivitis in children, infants, and toddlers. We have a very confusing picture right now, not just in our country, but across the globe in differentiating these diseases. Next slide. So when we look at the dynamics of occurrence of influenza in relation to seasonal variation, a study from Chennai, a 7-year cumulative study, almost 36,000 samples studied over a period of 7 years, influenza positivity started with the onset of monsoon and peaks during the post-monsoon months. Next slide. And when we look at the incidence of influenza and related deaths, we can see that this has been increasing between 2015, 2018, 2019. I do believe that the amount of surveillance and the monitoring of the cases and the investigations that are done, I believe that saying that these are the numbers are a serious underestimation, because we all know how many viral infections never get to the stage of being investigated and looked at. So this can only be a sound bite of what we are seeing, knowing that influenza causes about 500,000 deaths across the world every year through flu seasons. We can assume that a significant proportion of that, if not at least 10 to 20% of those deaths, would be in India, giving you much higher figures than what is being seen at one center. Next slide. Influenza is one of the most common infectious diseases. It is airborne, transmitted through aerosols. We know that it causes an acute febrile illness, and there can be even serious outcomes like hospitalization and death from this virus. Next slide. Influenza A is most frequently associated with epidemics because it has both the features of something called an antigenic drift, which is a slow gradual change in the neuraminidase and the hemagglutinin proteins in the receptor of influenza A. There are almost 16 and 9 respectively variants of these proteins. And there's also the antigenic shift, which is a sudden major change that occurs in the composition of the virus, and hence people who've even had it before are no longer immune to it and get the infection in large numbers. We all know about the swine flu pandemic that hit in 2009, again repeated between 11 and 13. And we've obviously had enough of influenza A in between all along. Influenza B infects only humans, causes local epidemics. Influenza C infects humans and pigs, and is generally a mild respiratory illness, not enough to cause epidemics. Currently, we have H1N1, which is the swine flu, and H3N2, which is the influenza A variant, which are causing the majority of the infections. Next slide. When we look at the transmission, just as we knew all along with the COVID pandemic, that up to 6 feet these viruses can travel through sneezes, coughs, loud talking, singing, and in closed spaces the transmission is even more. These droplets can directly land on mouths, noses, and I would say even eyes of people, because the conjunctiva was also seen as a mode of transmission. Staying away from infected people, staying home if a person is sick, so essentially isolation, which is so important if we are unwell and not going out to work and school. Washing hands, sanitizing, avoiding touching commonly used surfaces without then washing or sanitizing after touching them, and also making sure that we are masking is still extremely important. The transmission can occur one day before the fever begins and can last for up to 5 to 7 days after the symptoms have begun. Children can pass the virus for longer than 7 days also, so they can continue to shed the virus though their symptoms may have reduced. Next slide. When we try to symptomatically differentiate, you will see fever, myalgia, cough, lack of energy, sore throat is present in all of these, whether it's an influenza-like illness, whether it's influenza itself, whether it is seasonal or a severe acute respiratory infection or COVID-19. Breathlessness may be there in SARI, H3N2, and COVID, may or may not be there in the ILI, influenza-like illnesses. So that's rhinovirus, respiratory syncytial virus, adenovirus, parainfluenza virus. Loss of taste and smell primarily in COVID-19. Diarrhea, though it says in COVID-19, I would say H3N2 influenza can also give diarrhea. I have seen many cases in my career where We tell the patient you have a stomach flu because it starts with diarrhea, nausea, vomiting, and later on the respiratory symptoms come by. Headache is present in pretty much off and on in all of these illnesses at some point or the other, sometimes earlier than later. Later can be due to complications like a sinusitis developing and then headache developing. Earlier is due to the viral infection itself and its initial manifestations. Next slide. The emergency warning signs of flu illness, this is very important because when you're trying to select out whom to admit in the hospital, whom to start Oseltamivir in, whom to potentially look for as targets for very careful monitoring, these are things that you look in children: fast breathing, trouble breathing, bluish color of the skin, not drinking enough fluid, so risk of dehydration requiring IVs, not waking up or interacting. Neurological complications of influenza are well known both in children and adults. Being irritable, flu like symptoms, which improve and then return with fever and worse cough, that can sometimes be a sign of secondary bacterial infection that occurs on top of the influenza infection. Fever with a rash. In adults, difficulty breathing, shortness of breath, pain and pressure in the chest, abdomen, sudden dizziness, confusion, which is again a neuropsychiatric complication, can also be sometimes due to medication, severe or persistent vomiting, and flu-like illness that returns with a bacterial superinfection like we discussed. In addition to these, if the infant has inability to eat, trouble breathing, no tears while crying, significantly fewer wet diapers, this is obviously what we would consider dehydration, and that to significant dehydration, more than 10%. So in such cases, hospitalizations becomes a very important step. Next slide. The complications of any severe acute respiratory infection, pneumonia, bronchitis, ear infections, worsening of asthma, COPD, ILD also, interstitial lung disease, acute respiratory distress syndrome, much like what was seen in COVID with hospitalization, ICU admissions. Even the very well-known cytokine storms are well known with influenza. In fact, that's where they are most commonly seen before COVID came along, and then death due to complications like these mentioned. Next slide. We will now look at the management of influenza. Obviously, when we talk about treatment, before that, we briefly talk about diagnostics. And just a mention on that, the rapid influenza test can be sometimes not a very sensitive test. It's a very specific test, but not a very sensitive test, can miss up to 50% of cases. So really the RT-PCR for influenza, the nasopharyngeal swab and RT-PCR, or if samples are taken from the bronchi during a bronchoscope or a lavage or something, depending on the quality of the sample, picking up is much better with an RT-PCR. There are also viral cultures that are done, but again takes time to come back. But utilizing these investigations, we shall talk about it a little later in differentiating the illnesses. But treatment largely is supportive. We are looking at bed rest, fluid consumption, cough suppressants, antipyretics, analgesics, non-steroidal anti-inflammatory drugs. Most patients with influenza recover in 3 to 5 days. However, malaise, that is fatigue, weakness, muscle aches, can persist for weeks. Severe cases require IV hydration, supportive measures. Some, if they have drop in oxygen levels, may require even oxygen therapy in the hospital for their early management till they can be discharged safely. Next slide. When we talk about antiviral drugs, neuraminidase inhibitors block the neuraminidase enzyme, which is critical in releasing the viruses from the host infected cells. As we know, viruses take over the cell machinery of the host and multiply within it. And while multiplying, they then release millions of viral particles, which then go and infect other cells. So drugs that prevent the NA inhibitor, which are the NA inhibitors, can stop the active phases of influenza A and B. Oseltamivir and zanamivir are the common examples. The adamantanes, the M2 ion channel blockers, interfere with the hydrogen ion channel activity on influenza A alone and block the entry of the virus into the host cell. They are active against only influenza A viruses. So amantadine, rimantadine, which are typically classically used in hospitalized patients because they have special methodology by which they have to be given while in the hospital. So not commonly used in moderate cases, only in severe cases. But oseltamivir and zanamivir have a much wider influenza A and B activity versus the adamantanes, which work only on influenza A. So they clearly have an advantage. Next slide. Antiviral therapy with oseltamivir. Next slide. Potent selective inhibitor of the neuraminidase inhibitor, influenza A and B. Oseltamivir is a prodrug converted to oseltamivir carboxylate, inhibits influenza replication and hence spread to other cells, and hence the pathogenicity of the virus is reduced, prevents further spread of infection. It's effective in all strains of influenza A and B, including the avian flu, the bird flu, the swine flu, and then the H3N2 and the H9N2 variants of influenza A. Next slide. This is a graphic representation where the budding virus requires the neuraminidase, cleaves the receptor, prevents it from infecting newer cells and releasing from the virons, so it can't continue viral replication in other cells that it would infect. Clearly, the halted viral replication is what prevents the spread of the virus to other cells and hence inhibition of the disease activity, the duration of the disease, the severity of the disease, the progressive complications of the disease. All of these can be prevented if this drug is started in the early part of the disease. In the first 48 hours is ideal, but activity has been shown even 5, 7, 9 days into the illness depending on severity. Next slide. First inhibitor, as I said, 1999 in the US was the release, approved in more than 100 countries. Next slide. The dosages: adults 75 milligram twice daily when you're treating. Duration of treatment is always 5 days. If you're doing chemoprophylaxis, which means you have someone who was exposed to a case or is a high risk patient who might contract the disease because of exposure, then you're using once a day. In children less than 15 kgs, it's 60 milligram divided twice daily, which is 30 milligram twice a day. If it's chemoprophylaxis, which is for 10 days, 30 milligram once a day. 15 to 23 kgs, it's 90 milligrams per day divided twice, so 45 twice a day. It comes in a syrup form as well as in the tablet form, and for adults in the capsule form. So 23 to 40 kgs, you're again looking at 120 milligram divided twice a day, so 60 twice a day. In chemoprophylaxis, 60 once a day. More than 40 kgs, you have an adult dose that you would be giving such a child above 40 kgs body weight. 2 weeks and up is where this drug is approved from, showing you how safe it has to be that it has approval down to 2-week-old babies. 3 milligram per kilogram twice daily. There's no chemoprophylaxis in this infancy age. The suspension that you're looking at, which will be given to these children in the liquid form, is very much mentioned here. For adults, it's the capsule, as I mentioned. Ideally begin within 48 hours, but even older, at a later stage, if it's got risk factors, it's got risk of complications, the disease can be used even later. So do not think that if you have not started it in the first 48 hours, you can't use it. You can use it 72, 96, 5 days, 7 days. If the patient is hospitalized, going into the ICU or in the ICU, oseltamivir has been shown to benefit. I'll show you to you in the subsequent slides. Next slide, please. The 30 milligram capsule, next slide. Weight 15 kgs or less. Treatment dosage for 5 days, 30 twice a day. Prophylaxis 30 once a day. Convenience of dosages by having multiple ways of giving it. Next slide. Empiric use. So many a times we have cases where we do not have either the resources for doing the tests or the ability to get the report in a timely manner. And the question comes up, if you have a high suspicion that this is influenza that you're dealing with, do you wait for the investigations or you do empiric treatment where you start the drug? So this is a case that we are presenting, a 50-year-old man, farmer by occupation, no underlying comorbid condition, living in Srinagar, comes in with low-grade fever, sore throat, myalgia, sore throat has been there for 7 days, no chest pain, breathlessness, orthopnea, vomiting, or diarrhea. Before referral, he's had 2 rounds of antibiotics, ceftriaxone through injection, levofloxacin orally, not improved. Next slide. Pulse is 110, so he clearly is tachycardic for a 50-year-old. His blood pressure is normal, temperature is 100. Chest examination, there's bronchial breathing, coarse bilateral crackles. His CPK and LDH were high, which is not uncommon. Remember, you used to see high LDHs in COVID-19 also. Mid-zone infiltrates on the chest X-ray, nasopharyngeal swab. PCR shows H1N1. C-reactive protein is around 10. 5 is the cutoff, as you all remember. Cardiovascular, abdominal, CNS are normal. Lab evaluation is mostly normal. Liver function, ECG are normal. Next slide. This is the typical mid-zone infiltrates that are seen. Uh, these may sometimes not be present. So this is a case of walking pneumonia. But remember, if you do a chest X-ray, you don't have to wait to see this to treat as an influenza. You can get influenza even without these infiltrates. Next slide. Oseltamivir 75 twice a day, started for 5 days, analgesics, oral hydration, good hand washing. Patient shows good improvement. As you can see on this radiograph, the mid-zone infiltrates have pretty much disappeared or reduced significantly. And oseltamivir really made a difference in this patient. We all know that it's FLUVI that we are talking about in India. Has been around since the very early years. 2005 is when it was introduced, FLUVIR, into India. 2009, 11, when the swine flu pandemics were going on, it was a life-saving drug. FLUVIR has been exported to many other underworld and third world countries and has been a huge boon and benefit in battling influenza epidemics and pandemics in the past. Next slide. Oseltamivir treatment of influenza illness reduces LRTC, antibiotic use, hospitalization. Again, antibiotic use by 26% reduced. Influenza related lower respiratory tract complications reduced by 55%, and hospitalization by 59%. These are very significant numbers that you can see. Next slide. Reducing the occurrence and severity of pneumonia due to H1N1 by early oseltamivir administration, a retrospective medical chart review, 442 patients, median time from onset of symptoms to starting oseltamivir 5 days. So as I was telling you, it doesn't have to be the first 48 hours only, even up to 5 days they are showing. Subjects divided into people who got oseltamivir in the first 2 days, 3 to 7 days, 8 to 14 days, more than 14 days. Next slide. Both the probability of any severity of pneumonia and the probability of severe pneumonia increase gradually with the time from symptom onset to oseltamivir. So the sooner you begin it, the best outcome you see at 48 hours. But even if you were to begin it at day 3, 4, 5, 6, you can still reduce the risk of occurrence and the severity of pneumonia and shorten the hospitalization during the H1N1 pandemic of 2009. Ideally, because you do not want to wait for the investigations to come back and play around with other drugs initially, starting it in the first 48 hours gives you the best likelihood of reducing any pneumonia and any severe pneumonia. So try to target it and hit it early. Next slide. Patients with a shorter time to oseltamivir administration were discharged earlier from the hospital. No surprise here, because you're going to prevent viral replication. You're going to prevent further spread of the virus, progression of the virus. And clearly, you will see that the group 1, where they were given the drug in the first 48 hours, had the least number of days in the hospital compared to the people who got it in group 3 or 4 and ended up staying up to 10 to 20 days in the hospital. Next slide. Oseltamivir with azithromycin also can reduce secondary bacterial infections. This was an expert's review of respiratory medicine 2020 publication, so not too long back. Influenza A infected hospitalized patients identified, divided into 2 groups, one given only oseltamivir, the other given oseltamivir and azithromycin for 3 to 5 days. Obviously, this is a hospitalized group. This is not something that was done outpatient. Please kindly note that the combined treatment reduced the infection, the secondary bacterial infection, and reduced the need for respiratory support, as is clearly seen in this group. So, something to consider in your hospitalized patients. So, if you're admitting someone because they have high fever, they have progressive respiratory symptoms, cough, breathlessness, oxygen requirement, any of these things, they would certainly benefit from a combination of oseltamivir and azithromycin, especially if the disease has gone on for more than 5 days. You're worried about bacterial, and also if there are comorbid conditions in the patients. So if the patient has heart disease, has asthma, bronchitis, interstitial lung disease, and they're progressively getting worse, adding azithromycin might benefit. And certainly both antibiotic and oseltamivir can be given simultaneously together in such cases where you, as a physician, decide that the risk is high for these people to get sick. Next slide. Secondary bacterial infection, hospital stay was reduced clearly in the oseltamivir plus azithromycin group. Now here we are saying azithromycin doesn't always have to be this drug. You may choose a different drug depending on your community dynamics, results from your pathology lab of what kind of bacteria are largely circulating and which antibiotics those bacteria are sensitive to. You may choose a different combination, and influenza symptom severity score was also decreased. um, Dose adjustments are required in renally compromised patients. In liver disease, not much of an adjustment in dosage, but if the creatinine clearance drops below 60, then certainly certain adjustments in dosages which are there in the product monograph, you all are very much welcome to ask for a bit from your local representatives and follow it. It's in the package insert also. Next slide. What are the guideline recommendations? Next slide. Empiric treatment is strongly recommended in cases, as I said, where you suspect. So if it's a totally healthy adult, no risk factors, not a prolonged disease, they're getting better on their own, supportive treatment is enough. But if there are even the slightest of risk factors, then empiric treatment, even the WHO recommends doing. Negative lab test does not exclude the diagnosis, because remember, false positives, false negatives that we saw in COVID-19 clearly also occur in H1N1 and H3N2. So higher risk individuals who are exposed to a patient with influenza should also be considered for chemoprophylaxis, which is the once a day dosage for 10 days basically to be given. That's chemoprophylaxis. Next slide. Early empiric supportive therapy and monitoring. Give empiric antimicrobials to all patients who have likely pathogens causing a severe acute respiratory infection. Also, empirical antibiotic treatment should be considered on clinical diagnosis of community acquired pneumonia, healthcare associated pneumonia, sepsis. So basically hospitalized patients is what we are talking about. Empiric therapy with a neuraminidase inhibitor for treatment of influenza when there is local circulation, which means the flu cases are at a peak, at a high, are increasing, and risk factors are there. Also, travel history, exposure to animal influenza viruses. This is the Government of India recommendations where you should consider giving antimicrobials and antiviral therapy. So please do consider this in your cases, looking at the background of the patient, where they work, what they're exposed to. Do they have family history of disease? Do they have diabetes, hypertension, heart disease, chronic renal failure, chronic liver disease, chronic lung diseases? They have immune suppression. They are on chronic steroids or chronic immunosuppression due to autoimmune disease or other causes. They have cancer. They are going through chemotherapy. These are all the high risk factors in which you seriously need to consider giving antiviral therapy on an empiric basis if you have a high risk patient. Next slide. In adults with community acquired pneumonia who test positive for influenza, should the treatment regimen include antiviral therapy? Yes, it is recommended. American Journal of Respiratory and Critical Care Medicine 2019, this article said anti-influenza treatments such as oseltamivir should be prescribed for adults with CAP who test positive for influenza in the inpatient setting, independent of the duration of illness before diagnosis. I've had pulmonologist friends, my friends who are chest physicians, tell me that they have used oseltamivir even on day 9 in an hospitalized patient, and seen improvement very rapidly within 24 to 48 hours. Obviously, this is anecdotal, but there is enough data to suggest that if you have a patient inpatient and the disease is ongoing and progressive and risk factors are there, oxygen requirement, potentially going on a ventilator, this, that, and the other, oseltamivir is very much beneficial. Several studies have shown that it's associated with reduced risk of death in patients hospitalized with community-acquired pneumonia. Treatment within 2 days is ideal, but can result in best benefits, but you may see it even after 4 or 5 days of the symptoms beginning the benefit by using this drug. American Thoracic Society article and guidelines, this was recommended. Next slide. So in summary, proper diagnosis can lead to early treatment and can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory tract complications, hospitalization, antibiotic use. WHO, American Thoracic Society, and the Ministry of Health and Family Welfare in India all do suggest that empiric use of oseltamivir can not just benefit the patient, but also prevent the spread to other patients. Here we have not really spoken about the side effects or the contraindications. So I shall mention for oseltamivir, FLUVI. Contraindication would be a previous allergic reaction. Okay, previous allergic reaction to this drug would clearly contraindicate it, even if it is an anaphylaxis or an allergic reaction with hives, rashes, respiratory symptoms, anything that you believe is an allergic reaction to oseltamivir, should not use it. Also, if the patient has had Stephen-Johnson syndrome or erythema multiforme or any of these complications, which are not the IgE-mediated reactions to oseltamivir, but more the immune complex and the cellular-mediated reactions, in such situations, toxic epidermal necrolysis, clear contraindications to the drug. The side effects that can be concerning and is seen mostly in children but can be seen in adults also is the neuropsychiatric complications, including dizziness. You can get altered consciousness, you can get certain behavioral changes, and in all of these situations the use of oseltamivir, recognizing that it can cause neuropsychiatric changes, cognitive changes, is important. Remember that the influenza virus itself can give you neurological manifestations. So it's very hard to differentiate these, but certainly something to consider. The milder side effects of oseltamivir, like nausea, vomiting, a little stomach upset, a little irritation in the nose or throat, or which is possibly present with every drug that we prescribe as physicians, are things that we certainly need to always be aware about, but not things that would prevent us from using the drug, because the benefits of the drug clearly outweigh the risks from the drug. But certainly knowing about these things is very, very important. Um, if there are any questions that you all may have, please feel free to send it to us. I do have a couple of questions in my chat box that I shall take at this time. And Manohar, if we have other questions coming in, please share them with me.
Yeah,
Contraindications to oseltamivir, I have already told you. Yes, someone even in end stage renal disease with a specific dosage protocol on dialysis can take oseltamivir, because remember, over 60% of the drug is the metabolite of the drug is excreted through the urine. So the person needs to be monitored carefully. But for those who have their creatinine clearance above 60, can certainly take the drug without any problems. Can treatment with antibiotic and oseltamivir be done at the same time? Yes, it can be done simultaneously. As we've discussed, people have used oseltamivir with azithromycin in the past. Are any dose adjustments required in renal compromised patients? There's a whole chart for that. Please see the package insert. Please contact your pharmaceutical representative and their medical teams to get those updates. New antivirals, not really something, because we already have very good drugs. There are always research protocols going on to see if there can be something better, shorter, once a day dosage. But really at this point of time, oseltamivir is the most handy and readily available drug that we can use for treatment of influenza. Do vaccinated patients also need early initiation of antiviral therapy? If they have comorbid factors, if they are at risk for severe disease, if they have had a severe flu infection in the past, then even a vaccinated individual I would consider for antiviral therapy, because remember, the vaccine is from 6 months ago, the variants. Okay, to come out with a vaccine in the month of October or in the month of May, they have taken the circulating strains of the virus from 6 months ago and prepared those vaccines. And these vaccines, through what I call the antigenic drift, have constantly been changing and mutating for 6 months between the vaccine and now. So you may catch a viral variant or subtype which you are not vaccinated against. And secondly, the efficacy of the vaccine, depending on the studies that you look at, can range from 40% to 70%. So the vaccine is not 100% effective. So early initiation of antiviral therapy is recommended even in vaccinated individuals if they have classic influenza symptoms, empiric starting. And if you do a test, which would be the ideal case scenario, if it is accessible to you and affordable to the patients, I would certainly do it and initiate therapy and even start empiric therapy during such outbreaks as we are seeing now, because the cases are so widespread and rampant. Kids get it from school, give it to their parents, give it to their grandparents, and then they give it to their people at workplace because they don't stay home. So please stay home. That's one message to give to our patients when they are unwell. At least in the first 3 to 4 days, if they can stay home, they'll prevent the spread of the virus in the community and amongst their family and co-workers and friends. And wearing a mask, hand sanitizing, all are very important. Any other questions, Manohar, that we have?
No, sir. These are the questions which we have received, sir.
Okay.
So, yeah.
So once again, I think we have finished well in time. And we'll be having more of these webinars coming up. So you all are welcome to tune in if you all joined in late and missed any part of the presentation. And once again, thanks to Manohar and the entire Hetero Healthcare team for inviting me for this program. I look forward to connecting with you all in any form or fashion in the future. Certainly, there is a lot that we have to discuss. When it comes to COVID-19 and influenza, that's another topic that we mentioned. Co-infections are happening. The XBB 1.16 variant of COVID-19 is very much out there, and people can get both infections. If you get both infections, molnupiravir is something that can be used in COVID-19 infections. And Oseltamivir is something that can be used in the influenza part if someone does not want to go with the molnupiravir because its profile, and for whatever reasons, then Oseltamivir and treating the influenza part can also reduce the degree of comorbidity that will be there when you get two viruses together. So again, an important point for physicians to note when they are treating patients. Thank you very much, and hope you all have a good day and take care of yourselves. Doctors, please get your flu vaccines. If you all have not already done that in advance of the monsoon spike that will be seen in flu, I hope all of you all are taking a vaccine every year. That's the recommendation. And certainly vaccinate your patients also who require it and it's indicated in, especially people with chronic diseases and any kind of immune suppression or compromise. Take care and have a very good night.
Thank you so much, sir, for sharing your valuable clinical experience with a nice scientific way presentation of the entire flu management, as well as what are the current challenges and the management options. And certainly, this kind of presentation will definitely help all the delegates to understand. It will be useful to them in their day-to-day clinical practice. And thank you once again for sharing your valuable clinical experience with all of us. From Hetero Healthcare, once again, thanks to all the delegates who attended this webinar till the end, and looking forward for your valuable support. Thank you so much. Thank you.
Thank you. Thank you. Good night.